I broke my neck in 2005. It took me 18 years until I finally had my slide fixed. 18 years of opiates. And it wasn't until a patient advocate found me. It wasn't like I was going out searching for them. I thought I knew everything. And the problem with that is, if it took me 18 years, and I've been in the industry for 18 years, now more than 20, what's it gonna take everybody else? That's the why behind what I do. And what we do is advocate for advocacy. We're advocating through market research for your role and the impact that advocacy can have, not only on the industry, but on the patients' lives that you guys touch on a daily basis. But let's be real. For many of you, maybe you're sitting in a new organization than you were 18 months ago. For some of you might be in the middle of it right now. Aren't you tired of having to fight for budget? Aren't you tired of having to fight for respect? Or people thinking that in advocacy we shape clouds? Like that's not why we all got into patient advocacy. We got into patient advocacy for the impact that we can all have. Unfortunately, we don't have a problem with passion. We have a problem with the measurement and how we position the role. There's a mismatch. The anecdotes, the patient stories, those are woven very well by us, but they don't oftentimes make business sense to those at the top. As I've heard it put, if you've never been in advocacy, there's no amount of slides that will help you to understand what advocacy is really all about. And if you've been in advocacy, no slides are necessary. It's so true. But nonetheless, we have to prove our value to get a seat at the table. And what I'm hoping to do today is to say, let's provide you with what we're calling advocacy intelligence. So that it's not, can we get a seat at the table? We set the damn table. And it's our opportunity to lead. Before we move forward, I am gonna ask for you all to take out your phones and join me in a quick polling question. What I'd like to know is, how do you measure success? A, internal market research study. B, third-party market research. C, the number of engagements or meetings with our external partners. And D, some other predefined KPI. Give you guys a minute, let the numbers come through here. D, well in the lead. We've got 10 more seconds. Perfect. So, based off of what I'm seeing here, as you can all see, some other predefined internal KPI as the main metric there. Number 2, being the number of engagements and meetings with partners. Now, so that you're aware, and I'll touch on this here briefly, in our bioadvocate benchmark study, our bioadvocate benchmark is us going to you all in industry to say, what does advocacy look like? What does the function look like within your company? Size, budget, alignment, tenure, so on and so forth. Just if you go back to where we were with that last question, 83% of respondents there measure their engagement performance based off of the number of meetings. 50% use internal research, and 62% were using other external KPIs. So a little different than the population here in the room, but the key issue that we see is that 92% say that their function is underfunded. So are we getting underfunded because we're not measuring the right metrics for leadership? And what are the right measurements for leadership? 50% of teams in billion-dollar companies by revenue have just 1 to 5 people in advocacy. And I will tell you, by the end of this year, that number will probably be higher. And lastly, it's not like we're being asked to do anything less. If anything, you're being asked to do more with less. how can you keep up? We have to change the way that we've done things. To finish out and give you guys a little bit more data from Bioadvocate Benchmark, our hypothesis was that the number of disease states that your organization covers is typically where we thought we were going to see the growth in team size and budget, and that did prove out. But just so you're aware, you can see that exponential growth as you go from 4 to 7 disease states, averaging 5 to 14, about 9 full-time employees, to over 50 with 8 or more disease states. But those budget benchmarks also have some exponential growth to them as well. What I always like to point out is no company is spending anything more, it's usually less than 1.5% of your annual revenue goes towards patient advocacy. Now, if we were to challenge our marketing teammates and ask what percent of our corporate revenue goes towards commercials, I think the recent public numbers are somewhere around 16%. How about we take about 6% of that number and give it to advocacy, at minimum, right? And with regards to organizational alignment, what we're happy to see is that most organizations that are from a top tier perspective in our Elevate report, which is our second report that measures the feedback from the community about teams like yours, lead into a single direct report. May that be a chief patient officer, maybe even the CMO. Those that are just behind the top tier are led by a single leader who is at least 1 or 2 degrees separated from the C-suite, and then lagging 3 or more layers away from the C-suite. And we're in the midst of building out actually what we call the Elevate Index, which is an opportunity for you to take a quick 20-question assessment to say what's the current risk that you would apply to our function in patient advocacy. Are we being seen? Are we potentially not valued to maybe where we thought we should be? Are we involved to the depth that we should be? That will be coming. So you get a sense of where you sit, but most, as I said before, most of the problems that we're seeing this is an issue of underfunding, completely. And unfortunately, over the last 18 months to 2 years, that's only gotten worse. So how do we change that perception? How do we stop fighting to show our value and fighting to save our jobs ultimately and to fight to save patient advocacy? Well, you can do it differently with a different AI, advocacy intelligence, not the AI that we all know, okay? Let's talk about advocacy intelligence. Advocacy intelligence is us taking aggregated benchmark data that becomes intelligence. That advocacy intelligence represents your impact and ROI in that patient advocacy function. You're taking your stakeholder insights, both quantitative and qualitative, the identified market gaps and opportunities to continue to support the patient community based off of their needs, desires, wants, and all of the market research that your organization may have at its disposal from a commercial perspective. And you're able to measure the advocacy function's impact through the eyes of your customers. If you think about your marketing teams, they're looking at net promoter scores, the value of the brand through the eyes of the customer. Why not do the same from a patient advocacy perspective? I would say there's not a person in this room that doesn't think that they have great relationships with the organizations that you work with. It's true because you're all here in the first place, which means you're good at your job. But why not allow those people to be our mouthpiece from a third-party perspective? What's the value that you're providing? And then, of course, translating that into the language of our business to ensure that everyone else understands what that means for them. This is not another dashboard. This is a field-tested system, and I have proof of concept and where it's failed, where it's not been used. That we've seen companies unfortunately cut from 5 team members down to 1 in the last 6 months. And oftentimes it's because we don't get enough breadth within our organization for folks to know all that we do in advocacy. So why invest in advocacy intelligence? Well, ultimately, it's a strategic advantage. Just like we wouldn't do anything without market research and commercial, We should understand where our market is and what the research looks like for us in advocacy as well. It ensures that we are aligning our pipeline with the patient voice. That came up this morning as far as when are we engaging. I have some data that I'll share with you on that. It justifies the funding. When we all have to go around with a tin cup, God knows how many times a month or a year, but probably a month or a week. It allows us to be able to say, here's what we did last year in this snapshot in time, and look at the trends over the years. It fuels policy influence. Where are the current needs and issues from the patient community through the lens of the patient advocate, professional societies, and community-based organizations? What's their knowledge base? Because if that's who's educating the patient, then we have to understand what those gaps are. And lastly, benchmarking your performance with real metrics. Most importantly, metrics that you are within control of. Not the elements that you don't control, like pricing and going to market. But what does advocacy control? What do you impact? And measuring those elements. So our Elevate report is a report geared towards ensuring that we can maximize our influence as an advocacy function, provide you with the insights of what has your performance looked like over the last 12 months from organizations that have claimed to work with you in the last 12 months. So there's no lobbing of grenades from organizations that you haven't worked with. As we all know, you don't get to control compliance. You don't get to control what grants they approve or disapprove. So we don't want anyone who hasn't worked with you being able to provide a rating. So based off of their feedback, and we do this across the life sciences industry. Believe it or not, some of the payers pop up in many of the more common disease states like diabetes, COPD, respiratory issue, heart disease. So we're seeing a lot more influence of the payer in advocacy, and we have CROs as well. Our methodology, just briefly to touch on this, as I referenced, this is both quant and qual. We're looking to provide insights to you on not only the stack ranking and benchmarking of where you stand versus your comparator organizations, but what are all the key issues that are still impacting the patient community? Where are the opportunities for us to create new programs and address issues that remain? We ensure data integrity by not oversampling from any single patient advocacy organization. It's our job to get as many organizations as possible in the US. This is a US focused report. We do have global syndication as well, but the US focused report usually max 2 individuals from any given organization. We've been doing this for 11 years, I will say. Back to 2016 was the first time that we had an organization, and I won't name names, try to get an oversampling for their company. So that's why we have the cap. It's invite only to ensure that we have control over that. But where we've always been told the real jewels is in the qualitative interviews that we do with about a quarter of the quantitative respondent base. So we're able to not only understand why you ranked the way that you did, but what is it that they would have expected to see or hoped to have seen? What gaps did they see in the relationship? And what are other organizations doing that we may want to do? John Hoffman, who used to lead the team at Janssen, and for about 10 years, he had the #1 team, always had his team dissect their disease state chapter and come back with 3 ideas from what they found in the qualitative statements. It's how they remain #1. This just gives you a sense it's a meaty report. There's a lot of data. That's why when you purchase the report from us at Archo, you get 1 year of complimentary consulting from us as well. We're here to come alongside of you, help you digest the data, help your team digest the data, speak on your behalf within the organization about what these results mean, and again, advocate for you. We have different ways we can slice and dice this data, including custom reports. May you say that we're in a very niche environment, but we have about 24 different disease state reports. We have our executive summary, which you'll see some slides on today, which is all respondents. We have specific policy level reports. Really, we've done this to ensure that if it's a budgetary issue, you can get other folks, maybe in government affairs, to pay a piece, whatever that might look like within your company. But our health equity report has been something that we've been running for the last 3 years, but note that that very top line includes everything that you see below, okay? The second report is that bioadvocate benchmark, which I referenced earlier, which was not going to the nonprofits, but going to you all to understand what does the function look like. That's the function. And here's, just to give you line of sight, this is preliminary. I will have final data on Friday, but I did want to give you guys a look at what the measurements begin to look like. And this is taking those 8 stacked rank sections, aligning a point value for 1st through 10th place, which is hard enough to become number 1 in any of the 8 different stack ranked areas. And then totaling up those points out of 80, and you can see where the different organizations fall out. It's the first year in the last 11 that we ever had 2 organizations tied at number 1, with Janssen and Pfizer, or CGen as well. The CGen folks, I will say, if you are in the room, you got plenty of shout outs on behalf of Pfizer, so know that. But the measurements are not just who do you think is best at X. Okay, there's no softball questions here. We want to understand the elements that make up that metric. So, for example, in corporate image and reputation, one of the leading indicators for your score is the organization provides access to leadership. Sometimes that's within your control, within the advocacy function. I would argue that it definitely is. The problem is do they understand the value of getting out into the community and interacting with these folks? That is the key. But that has always been a driving indicator for the overall impact that you can have as well. So corporate image is an important piece, but it's only one piece, right? When we look at programmatic and partnerships and programmatic support, we're looking at 12 different areas of programmatic support, from disease education and awareness, through patient registry support, clinical trial collaboration, so on and so forth. And we do have a weighted scoring system, so that if you have a large sample size or a large response rate for your organization, you're not dinged, because what we typically see is when you get above that 20% for a response rate, that's where the negative comments start to come in, okay? So we do have a weighted system, and what we're working on right now is how can we use that weighting to appropriately break out organizations by, let's say, revenue quartile. Top 25 pharma companies by revenue, second 25, third 25, and fourth. But as I referenced, it's not just at a snapshot in time, how do we look? What are the challenges that are still crippling patients? Well, continuity of care throughout the health system, communication gaps in health literacy, and disadvantaged and vulnerable target populations is the top 3. All issues that I know many of you are working on. Interesting to get a better understanding of how health equity has weathered the storm within your company. But needless to say, health equity, health literacy, both massive issues for the community. As was asked this morning, when do you get involved? Well, this is data from those 2 surveys side by side. On the left, bioadvocate. Again, you guys in industry. On the right, from your nonprofit partners. When do they want you to get involved? Phase 0, phase 1. Okay? As you see there, about 81.9% want you to engage in phase 0. Unfortunately, what we see is 83% of industry does not get involved until 18 months from PDUFA date. So we're not in alignment there. When it comes to some of the political issues and access problems like AFPs, accumulators and maximizers, and non-med switching, knowledge is still lacking. And we've been at this for, what, 10, 12 years in some of these issues? As I believe Stacy had said earlier, these folks are hurting. You think industry had turnover. I'm sure you're all seeing new people within the nonprofits that you're working with. So we have to do that educational element all over again, especially from a policy perspective. Even more so, the request from the nonprofit community is, can you help us rebuild coalitions? Remember all those great coalitions we had back during the ACA? Where'd they all go? As we referenced, identifying those gaps. If we're looking at partnership and programmatic support, we have a separate slide like this for policy. Where do they want support? As you can see, some of the biggest gaps, disease education and awareness. Surprise, surprise, right? However, coalition support, number 2. Number 3, advisory initiatives. What you're seeing in that slide, just to make it clear, gold is the level of support they wish they had, blue is the current level of support that they're feeling. Here's that same slide from a policy perspective. I know not many of us in this room are focused on the policy issues, but really what are they saying is, we don't have the time to go through the policy issues or know what's happening, so please let us know and please educate us. What we saw in doing this data for the last 11 years is prior to COVID, we had about 76% of the disease state nonprofits engaged in policy work. COVID came, that number dropped to 21%. We're now back up to 54%. So they're slowly getting back, but the policy wonks that they had are not the same. And then health equity. The desire from the community continues to grow. Where do they want support? Continued individual education, social support networks. I can't remember if it was Day One or another organization that had talked about creating peer programs for patients this morning. That's the type of support that they're looking for their patient community. And of course, systemic barriers to equity, which I would say are the hardest to address from industry's perspective. They're still recognized as major issues for the patient community, and we have to come alongside of them to understand what is the organization looking to tackle and how can we be of assistance. But note that our work always looks to get beyond the funding. This should not be a game of who spends the most looks the best. In fact, 9 times out of 10 doesn't look that way. It's what do you control? You oftentimes don't control your budget, unfortunately. So we want to make sure that we reflect that as well. And then health literacy. What you see here is the majority of the respondents will note that their patient community is somewhere around the 5th grade reading level. However, if we remove oncology and rare disease from the report, it drops to between 3rd and 4th grade. Rare disease and oncology skew towards 8th grade, which makes sense. Long diagnostic odyssey, lethality of disease, they're going to educate themselves. Diabetes, COPD, heart disease, 2nd grade. How are we addressing it? Have we even thought about how we get to 2nd grade reading level? And then proof that it drives results. Well, what we've been able to do is help drive recalibrating of budget decisions by disease state. Literally going with one large pharma organization to change the way that they were staffing different disease states and ensure that the budgeting aligned with that. Helped elevate advocacy and, more importantly, health equity into business reviews for all departments. All departments had a health equity initiative that was spearheaded by the advocacy function. Used benchmarks to defend headcount, especially the bioadvocate benchmark. Aligned equity goals, health equity goals, with business outcomes. And again, helping these advocacy functions to speak the language of the business. Quick case study for you. If you bear with me, I just want to double check one element of this. And Iffy, I think we've got 2 minutes, 3 minutes, 5 minutes. All right, we're good. Perfect. With regards to this particular organization, but unfortunately I will have to keep nameless. Diabetes space medical device company. Major problems with their insights not spreading throughout the organization or to their market access teams, meaning the advocacy insights. Leadership wanted to push forward on health equity. but had no understanding of what that even meant. They just knew it was the new buzzword 2 years ago, so let's jump into it. In fact, they were looking at maternal health as their main initiative, though they have a single product for diabetes. And the executive leadership team did not understand the value of the patient advocacy function. In fact, the perception of the patient advocacy function was that they should all be fired. They were the #1 patient advocacy function in diabetes. That was the mismatch on the perception versus the reality. So the solution, as you can see here, we helped map out stakeholder barriers, both within the company and within the marketplace, to ensure that we had alignment and that the influence and impact their advocacy team was having was spread throughout the organization. We introduced many different teams and executive leadership teams to the advocacy intelligence data. That was a shock to the executive leadership team to learn that they were the #1. Because when they went with them to these meetings, it just looked like cocktails and fun. They didn't see all the work that goes in behind it, as you all know. And helped execute landscape mapping for patient advocacy organizations focused on the health equity initiative that we thought would align with their corporate mission, and more importantly, where the executive leadership team wanted to move. So we're actually able to pivot off of maternal health to gestational diabetes and get them within a line of their business. There's now a newfound respect. Unfortunately, prior to us being able to do this, they took that team of 5 down to 1. As they also pivoted from diabetes to cardiometabolic. And for those of you that know the cardiology space, that takes some major funding and a lot of people to get involved in the cardiology space. They now, unfortunately, they've gotten 3 headcount back. Still not enough, but we're making moves. The other team, I won't say the name, but if you're paying attention, you probably know who the company is. Remained at the top of our report for 11 years straight. And again, the problem for them was that advocacy work lived in silos. And they battled, of course, competing priorities from commercial, from market access, and from government affairs. And they continued to face resource constraints, though they had a team of 58 and about a $28 million budget. That was just discretionary spending. That is not anything to do with the folks within the team. So for us with the data, it was translating that 12-month of patient input into the executive level KPIs that they would understand, that aligned, again, with the business initiatives and focus. We worked with the different disease state teams to curate and query the qualitative feedback, to identify the market gaps and opportunities, to keep them in that #1 spot, the new things they were going to do or double down on. And for those of you that know of the Ideas Summit, that was born out of this process. The impact here, well, they elevated the advocacy function into commercial. All advocacy advocacy got to look at all commercial plans before anything happened to identify where advocacy should be involved, #1, or be a lead, or at least partner. They created an advocacy implementation index, something that we are now using for other organizations, which is just what is that level of support that we're getting from the rest of the organization, and have seen budget increases for 10 of the last 11 years. The key here is converting that advocacy intelligence into leverage and using that leverage to ensure that we can convey the value that we can provide if we're funded and supported the way that we all know we should be. It's our job to empower you at the end of the day. That's what we seek to do. And if you can't quantify your impact, you're only one reorg away from irrelevance. And as I said, if I go back to my why, if it wasn't for a patient advocate, I would not be standing here. I can't look down, literally, but I'm an inch taller. I'll take that any day. If it wasn't for the work that you all do, I would not be here. More than likely, opiates would have taken me years ago. So it's ensuring that we can defend the work that you do, empower the work that you do, expand the work that you do, and speak that to the highest levels of your organization. Advocacy only survives if it scales. If we can't get breadth within our organization and touch every single department and have some sort of alignment or buy-in from one stakeholder within each department, we're falling short. So I challenge you to ask yourself, can your impact be tracked? Will your work survive without you? And are you moving from insight adoption to true impactful outcomes that the organization actually cares about? Before I leave the podium, those two studies that I referenced, we have white papers for both of them at our booth next door. You can scan the QR code and grab those white papers. One being the value of patient advocacy. I just did a recent TED Talk on that as well. But we try to say all the things that maybe your compliance team won't allow you to say. Like the cost savings that you are able to provide in clinical trials, how you set the market commercially for a successful launch because you have advocacy out in front. We put all that down for you in that one white paper. Second one being the bioadvocate benchmarks and the key insights from that for what is the right size, budget, and alignment of your team. Stop attempting to translate the work that you're doing. Let us do it for you, or at least let us see what you are working with to tell you, is there enough meat there for you to get the buy-in? Start driving upstream organizational strategy. Be seen, and don't be quiet. When it comes to a patient, we are the loudest people, but unfortunately, when it comes to ourselves, we're maybe a little too quiet. And lastly, deliver patient advocacy and health equity wins the C-suite will respect. And we can only get them to respect it if they respect the value of our work in the first place. With that, I thank you.
We are open for a few questions. If you want to ask a question, please raise your hand. So I'm going to ask you a question, and this might be non-PC. Part of the challenge we have is justifying engaging a consultant like you